be able to talk to doctors in India for the first time. I hope everybody can hear me well. I have to switch off my sound because there's a huge echo. So I think if you can hear me well, everybody can hear me.
Fine, no echo is not much.
Can you hear me like this?
Yeah, we can hear you.
Okay. Then I will continue without my own sound.
Yeah.
So we'll get started. This is the symbol, the logo for glucopuncture. You recognize the glucose or dextrose molecule in it. And it's a green drop because we consider it as a treatment which supports the tissue healing, not suppressing pain or inflammation like steroids. And in the next slide, you will see the definition of glucopuncture. Glucopuncture is a non-steroidal injection therapy using sugar water 5%, so it's a very low concentration. This is the isoosmolar, or sometimes also called isotonic solution. And we use it for the management of a variety of musculoskeletal conditions, such as joint pain and even neuropathic pain, and one exception also for Dupuytren's. The main goal is of this course and of these slides is to use these sugar water injections instead of steroid injections. And there is still a lot of work to do because in Europe, the majority of the doctors in the hospitals are still using steroids, despite a few very beautiful randomized controlled trials, especially on the treatment of carpal tunnel syndrome, where there has been obvious, how can I say this, an obvious proof that the sugar water injections after 5 months or 6 months were as good as the steroid injections without the side effects. So what is the definition of glucopuncture? We inject glucose of 5% in water, which is mainly used in Europe, or dextrose of 5% in water, which is more popular in the United States. And it's important that we are using isoosmolar injections. Sugar water is a solution, an injectate. If you inject it, not into a joint, but into the extracellular matrix, then it's important that it has the same osmolarity than the cells. If you go too low, like 2 or 3%, or too high, like 20%, then you will have osmolar cell destruction. Hyperosmolar means, like in prolotherapy, too much pressure, the cell will collapse and get destructed. If you give very low in concentrations, you have hypotonic solutions, then the cell will blow up and also collapse. So in glucopuncture, we always use isoosmolar injections. No local anesthetics are required, and as I said before, no steroids. There are 2 types of glucopuncture, the patient-guided, which we will discuss today, where we use our hands and the sides of the patient, guided by anatomical landmarks, and B, screen-guided glucopuncture. This is more popular in hospitals where you use mainly ultrasound to get your product exactly at the right spot. Like, for example, perineural injections for carpal tunnel syndrome. If you want to go perineural, you need, of course, ultrasound. So where does it come from? It's started in the 80s. As I said earlier, this technique goes back several decades. And I was, as a medical student, I was a pain patient for low back pain myself. I got in touch with German neural therapy and Austrian therapeutic local anesthesia. And I bought a book in the 80s. The one I have here is one of 1989. And I discovered the use of local anesthetics. They mainly used Procaine. And we started with Procaine 1% and dextrose at 10%. And then came the Korean article in 1997 by Dr. Kim, and they said that local anesthetics and dextrose had the same effects for injecting trigger points. This is the book, the German book about therapeutic local anesthesia, and you see where they inject a lot, for example, in trigger points, in pain points, and so on. And we started to give a mixture of Procaine with glucose at 10%. So the net concentration is 5%, which is isoosmolar. And the Korean article I was talking about was the first one in my search of the literature to mention glucose or dextrose 5%. We are talking about the late 90s. And we started to give these intramuscular injections a lot, and we noticed very good results. And then we also started to use them for ligaments, for joints, and for fascia. And this is the article I'm referring to. You can still find it back. Originally, it was only available in Korean. Only the first in India, the summary was in English, but the rest was all in Korean. But they definitely said that the dextrose 5% was better than saline and lidocaine for trigger point injections. So after seeing this article, we were more convinced that glucose was not a placebo, but was a true agent with a specific effect, clinical effect, when treating musculoskeletal pain and dysfunction. And in the beginning, we usually injected into these muscular trigger points as described by Trevor and Simons, and the Americans who did that last century, and also later on in pain points and trigger points, and also into ligaments. And here's, for example, injections with a 4-centimeter needle into the calf muscle for a sports injury by a runner, for example. So in the beginning, we used the procaine, then we started with adding the dextrose, and then in the end, we used even the dextrose on its own. Now, there is another technique which is much older, that is prolotherapy. And prolotherapy is an American technique. It is invented by American doctors almost 100 years ago. And it's part of the regenerative injection techniques, where a small amount of an irritating solution, this is a definition from one of their books, is injected mainly ligaments, entasis, and joints. And the goal is to promote cell growth and tissue proliferation, hence the name prolotherapy, proliferation. And the injectates they started with was phenol, which is a very dangerous product. They stopped for it because of safety issues. Then they started to use sodium morphate. And then later on, I think this was like in the 70s or 80s, they started to use hypertonic solutions. You can use sodium chloride 3%, or the more popular one, dextrose of 15 to 25%. And because of this, let's say, very irritating product, it's very painful during injection. If you don't believe me, inject yourself with dextrose of 15% without local anesthetic. It's very painful for a few minutes. So that's why we need to add local anesthetics when applying prolotherapy. And the mechanism of action is completely different than what we see with the glucopuncture. And I will explain you right away, because the cell destruction leads to foreign material in the extracellular matrix, because the cell membrane collapses. All the phospholipids and the other intracellular material comes into the extracellular matrix, and the body recognizes this and starts as a reaction, a local inflammatory reaction. But that's the goal. This takes several weeks sometimes, but this regional inflammatory reaction evokes a natural response, a tissue repair response, which can take several weeks. That's also why in prolotherapy, for chronic diseases, they typically wait about a month to 6 weeks for the next session. So the result is proliferation of connective tissue. And they have done some research mainly on the tendons of rabbits, and they saw that the ligaments or the bands became stronger and thicker. So for me, the prolotherapy is mainly for weak ligaments and for thin joint bands. Like, for example, you have a weak ankle. I prefer still the prolotherapy to the glucopuncture. One can also give joint injections, but there is no prolo effect because there is no proliferation. You inject the sugar water into the cavity, into the liquid, and then it has no prolotherapy, but it was still used, described as prolotherapy. And I followed the prolotherapy out of curiosity, although I was already using these products for quite a while. I followed the course, I think it was 2005 in Italy, with Professor Patterson from the United States. And I enjoyed very much, but I still preferred my own techniques. I didn't tell them that, but that was what was my own opinion. Then you have Dr. John Liftoff. He's very famous because he was the one who brought the glucose of 5% or dextrose of 5% injections into let's say even into the world. He gave a lot of courses worldwide, and his first publication was for the Achilles tendon, and he called it subcutaneous prolotherapy. But again, if you inject subcutaneously with 5%, there is no proliferation. But everybody associated the word glucose or dextrose with prolotherapy, and that's why the term prolotherapy was used. And he was the one who introduced this regional application of multiple injections with sugar water 5%. And he also uses a buffered glucose or dextrose. I had him on the phone like 20 years ago, and he said, yes, we add some, we try to make the pH around 7.4 because that is less irritating. After a while, then he started to use the injections close to peripheral nerves, and he called it PIT or perineural injection therapy. And I followed that course in Greece a few years ago. I was very curious, like they're using the same product as I'm using. What are they doing differently? And their technique is more sophisticated than mine. I will explain you later on. Mine is more for beginners. And those doctors who have followed a glucopuncture course, I usually say, if you like it and you want to go further and deeper, you can go, for example, to Dr. Cavallino in Italy and contact him because he gives courses on PIT worldwide these days. And they follow the peripheral nerves and they give multiple injections, similar to the glucopuncture that I will talk about later, subcutaneously close to the peripheral nerves. And it works very well. This technique is really successful, and I am positive about the results that I have seen. Now, we are talking now about the glucopuncture itself. Glucopuncture is not just around peripheral nerves. It's not just about muscular trigger points or ligaments. We have the four major layers. We're not going to talk about the joint injections today, but the four major layers are intracutaneous, which we use for neuropathic pain. You can find one of my publications on PubMed for herpes zoster, for neuralgia in the skin, which is very painful but very effective. I stole the technique from the neurotherapists in Germany. Then the intravascular injections, which is more a recent, let's say, description. We give subcutaneous injections for vague pain for decades, but we realize now that the effect can only be explained by the vascular system, the vascular integrity. Maybe we'll have time today to talk about that in more detail. Layer C, intramuscular, which means that we are going to inject into the muscle, which can be deep or less deep, depending on the muscle. And we inject in pain points and in trigger points. And layer D is in ligaments. This is mainly for ligaments which have been damaged through, for example, a car accident or a fall. And then we, like in a whiplash, and then we inject specifically in the ligaments. So as you can see, it's already different from the PIT that we inject in 4 different layers. PIT is only in subcutaneous around the nerve. We inject in these 4 layers, and we also are based on more clinical examination that we are looking for pain points and triggers. And I will explain that right away. So, for example, here you see a patient who had a whiplash, and she was injected into the nuchal ligament in the neck for pain, which was over here, which was referred pain. This is a patient who had chronic pain in the dorsal area. X-rays was normal, MRI was normal. She was given multiple injections with glucose of 5% in the fascia in this area. Here, for example, this is without ultrasound. So you know that maybe glucopuncture is mainly for low-income areas where the doctors don't have an ultrasound equipment, but still want to help their patients. We give injection in the fascia very superficially, not only here, but we also go up the forearm. And if we have time today, I will talk about that as well. I told you about the intramuscular injections. Well, sometimes we use an 8-centimeter needle, which is quite a long one for the gluteus minimus muscle. And for those of you who are familiar with trigger point therapy from Travel and Simons, referred pain, which looks like sciatica, which goes all the way to the ankle, can originate from the gluteus minimus muscle. And then we inject glucose 5% or dextrose 5% in that area. And it's of course important that a physician looks for those pain points. For example, here in the ligaments of the lower lumbosacral area, on the midline, or the sacroiliac area, you use your thumb. We are not based on X-rays, ultrasound, or MRI. Clinical examination is considered very important in glucopuncture. So over the years, we have developed new blind injection techniques, and the majority of them, especially for the beginners, are shallow injections where we inject into the skin or in the superficial fascia. The ones in the skin, as I said before, is for neuropathic pain. The others are more for vague musculoskeletal pain patterns. And this means that the patient says, oh, I have pain here. And then you say, okay, it starts from the trapezius. It goes up the shoulder and it goes into the deltoid. What is it? And in the beginning, we didn't know what it was. And now we realize, but the fascia, the superficial fascia, is a key, plays a key role. And many doctors now worldwide are confirming their findings by just injecting subcutaneously in the superficial fascia. You have pain modulation, even in chronic cases. This is the one of IC, intracutaneous. You see how you superficially inject? They are very painful. They are very painful. It's like you're bitten by an insect. It's very painful, but very good for neuropathic pain. The same here. This is published also on the internet. You can find it on PubMed, the case of herpes zoster of this 88-year-old lady. After maybe 4 or 5 sessions, her pain was almost completely gone. You can also inject into the fascia for example, the neck area, and this can be used also for pain not only in the neck, but also for pain lower or pain in the head. Now, it's obvious that the glucopuncture is mainly designed for doctors, for example, in Europe and the United States, who want to switch from steroid injections to a safer option. But we also want to introduce it, and you find more information and a free online course on this website for doctors who, I have received emails from doctors from Bali, for example, from Indonesia, who said, without any ultrasound, now I can help so many patients just by injecting sugar water 5%. And here, this is typical for patient-guided glucopuncture. The patient says, I have pain here, and it goes there, and then you inject in this spot. This patient says, I have pain here. X-rays were normal, MRI was normal. We inject, for example, here in the fascia, in the area. Same here. Here I found deeper points, so I will inject into, for example, the paravertebral muscles. This patient has pain quite superficially on the right knee on the medial side. Ultrasound was normal. We injected very superficially, and we had good results by just injecting into the subcutaneous or in the superficial fascia. Another one, the patient shows you where they have the pain, and these are the points that you can inject. So you give multiple injections of sugar water 5% in the pain region. And sometimes you have to find, for example, here, these trigger points in the infraspinatus muscle or rhomboid muscle. They can produce shoulder pain on the front side. So these are injected as well. Here the patient shows you where he has the pain, his left knee on the lateral side, and you are going to look for pain points in the area or trigger points more proximal. And these trigger points can also give referred pain. We call this examination-guided glucopuncture. And it's perfect for doctors who have no ultrasound and have no access to a hospital with MRI in the neighborhood and still want to help their patients. And we sometimes inject into trigger points outside of the pain region. For example, this is a patient who has pain in the arm here. We inject some points here in the pain region, but we also inject into the neck, the trapezius muscle, infraspinatus, and deltoid muscle. So as I said before, this is designed for doctors who are already doing the dry needling or neural therapy or PRP injections or PIT injections. And we hope that more and more doctors are going to experience the results that we see. But when you want to be very accurate and you want to go deeper, it's obvious that you need ultrasound guidance. There can be a reaction phase, and this is true for every injection technique. but you can have a worsening of pain and swelling in the beginning. Please explain your patients that this is not necessarily a bad sign, but it can be the starting up of the inflammatory healing response or regeneration of tissue response. And this is more likely when you inject into pain points or trigger points. And also some patients, we call them the hyperreactors, are more likely to have a temporary worsening after the injections. Sometimes it is possible that after 2 or 3 sessions, when you're treating chronic pains, the pain may relocate, and you will just follow the pain and inject in the new areas. So what are the major goals of glucopuncture? We want to modulate regional pain. That's maybe 80% of what we do. We support tissue repair, and recently we understand that we also regulate vascular integrity, which has biomechanical importance, and especially osteopaths and chiropractors are amazed that when we do a few sessions with the glucopuncture on the fascia, that their manipulations or adjustments, for example, of the spine or other joints, goes much more fluently. The application is typically in fresh lesions twice a week even, and we take 1 or 2, 3 sessions. If it's chronic, we usually start with once a week, then we go to every 2 weeks or every 4 weeks. This is big difference with prolotherapy, where we always have to wait 4 to 6 weeks for the next session, because the proliferation takes about a month. And of course, for chronic patients, you have to wait a few sessions before you can see the results, because we're not suppressing symptoms. We're not injecting painkillers. We're not injecting steroids. We are asking the body to repair itself. And the sugar water, one of its effects is that the ATP in the cell, in the mitochondria, will recharge the batteries. So you support the natural tissue repair. As you have seen in the photographs before, we typically give multiple injections each session. For example, here the patient has pain here. If you are a beginner, you just give multiple injections in the pain area. For example, in the fascia, vascular pain region, FPR. And I'm going to talk a bit about that, about the superficial vascular, because it's becoming so popular over the last years. And we can inject, as I said before, in the origin region, in the neck, and in the pain region, but also we can inject in some trigger points. These are very easy to give, and we give them subcutaneously. And we have seen that it's very interesting for fake pain. The patient shows you a large region. Then what is the pain? Is it a muscle? I don't think so. Is it a ligament? Very unlikely. Is it referred pain from, let's say, a hernia in the neck? Unlikely, because it's not the right pattern. Please don't believe anything of what I'm saying. Please disbelieve me, but test me. Check me out. Do it on yourself, do it on your partner, or on your parents or your children, whoever you get your hands on, and try to give simple, multiple subcutaneous injections in the fascia, and then you let me know. You can go to the free online course on the website that I showed you earlier on, where you can see some videos. We won't have time for that today. And then you will see that this is like wonderful. We will skip a bit to the anatomal fascia anatomy because we don't have enough time for this. But this is a good drawing to show that fascia, which is in a knot here, can influence on the shoulder on the other side. This is really, especially osteopaths, they speak the same language. They understand what we're talking about. And we give at random in the pain region, in pain points, or in trigger points. For example, this patient has pain in both shins. He has tried many different techniques, including even PRP. But we only gave injections into the fascia, 5 times 1 ml, so a 10 ml total. And we inject tangentially always for the fascia to get as much in the superficial layer. In this case, also to avoid injecting periods. Here, for example, the patient says, I have pain in this area, then you will inject in the fascia in that area. It's too simple to believe it's true. Please test me. Don't believe me. Another one, chronic pain in the neck. I've seen so many doctors before me. I just give injections on the midline, on the left side, and on the right side with the same sugar water 5%. And after 3 or 4 or 5 sessions, she was much, much better for the first time in her life. It's too simple to be true. Same here, patient says, I have pain here. X-rays, scans of the hips were normal. Ultrasound of the abdominal and the lower area here was all normal. We just injected in the area and the pain was gone. Sometimes you have to look for pain points in the fascia or deeper and inject these. This is an example of referred pain. On the left side, you see that the patient has pain on the right knee on the front side. And when you do the examination, this takes you like 15 seconds. You don't find any pain points here. You go and look up and you can find several trigger points, either in the fascia, which is superficial, or if you have to push deep with your thumb into the quadriceps muscle. In this case, was fascial trigger points. So you inject here and the pain may be gone after 2-3 sessions without injecting the pain region. Sometimes the patients are a bit disappointed in the beginning that you don't inject when they have the pain, and surprised that after a few sessions, they get much better. Same here, very popular in my practice. Heel pain or Achilles tendon pain, a bit vague. The pain starts here and goes to the foot sole on the lateral side. We go and look for pain points and we find several trigger points here in the calf area. Please, again, try this at home. And in some cases, when you don't find superficial pain points in the fascia, you will have to push deeper with your thumb and you may find those trigger points in the muscles. And this is a bit what I was just explaining. This is another one, a patient with pain here in the Achilles tendon, and here are the fascial trigger points. And we call this referred pain from the fascia. You can also have patients who have pain in both legs, and it comes from the fascia of the lumbosacral midline. I have had a patient with pain in both thumbs, tried several techniques. I started to inject the fascia on the neck midline. This is what we call the origin region. We don't have enough time for that today because we are a bit limited, but just to give you an idea. This is a patient with frontal headache, and we inject the fascia in the occipital area. Very easy to do. This patient has pain for 2 months, and we gave the interfascial injections, no local anesthesia. After 2 weekly sessions, her neck pain was gone. She had it for 2 months. Is this safe? Easy, and it can be very effective. Not always. Sometimes it's a bit more difficult than this one, but it's worth to do the test. It's worth to try and find the trigger points, for example, in the ligament, the nuchal ligament. Then you have to inject a little bit deeper. Here a patient with pain in the right foot for 4 months. X-rays and ultrasound were normal. We give injections in the fascia in the pain region, like 10 injections of 0.5 ml. With a 30G needle, which is like very, very thin needle. And after 3 sessions, our pain was gone. We were just injecting the pain region. And it's worth trying. It's really worth trying. Another one with neck pain received 6 ml in 6 points with the 27G needles, and pain disappeared, in this case, after 5 sessions. So the pain was starting from here and going all the way there, where his hand is, and we injected in the neck and in the trapezius area, all of them in the subcutaneous fascia. Lateral hip pain, this is very common, especially ladies. In this case, 3 years, not 3 weeks, 3 months. This is 3 years, mainly in the fascia lata. And she received about 7 interfascial injections in the pain region, each time about 2 ml, which is not as much. I am using more volume these days with the 27G needle. And the pain disappeared after 8 weekly sessions, after 2 months, but she had it for 3 years. So don't forget that you don't expect results after 1 or 2 sessions. This will take some time. We are supporting the innate repair mechanisms of the body. So that will take some time. Sorry. And so this is where we were injecting. She said, my pain is here, and I injected in the pain region. It's very, very simple. Same for someone who had so-called joint degeneration. I injected, she said, I have pain in the whole area, not just one particular articulation. No, the whole area. So I thought maybe it's muscular or fascia. When I pushed on my finger, I only needed light pressure, which means it must be superficial. So I injected in the subcutaneous fascia. Same here, so-called joint pain, subcutaneous in the fascia, not into the joint. Injecting into the joint of the finger is complicated, a bit risky, and sometimes painful. Try this first at home and see what happens. DMG joint pain, so-called joint pain. She was much better after a few sessions in the fascia, in the pain region. She said, I have pain here. Same, of course, for the Achilles tendon, sometimes one lateral side, like here, sometimes you do medial and lateral side. It depends on each clinical case. I showed you this one before, referred pain coming from the fascia above the knee. And then, of course, we have deeper fascial tissues, which is less common that we inject. For example, the fascia lata itself or Dupuytren. And let's say that Dupuytren grade 1 is an interesting, let's say, indication for glucopuncture because it is not pain treatment. Glucopuncture is much more than just pain modulation. Another difference with prolotherapy, another difference with PIT. We also inject organs. I have a publication about IBS treatment. I have a patient with gastric pain who has been treated by injections in the fascia. We also do Dupuytren, but only if you are early, grade 1. And then after 2 or 3 sessions, you yourself will feel the difference, that it becomes less hard, softening. And I've published one of those patients. I think it's this one, this particular patient on PubMed 1 or 2, no, maybe 2 years ago, where the lesion disappeared completely. If you're waiting for grade 2, you can only stop it because then it's too late. And grade 3, you don't have to start. But I don't know how it's like in India. But we in Belgium, in Europe, we mainly inject steroids, which doesn't help on the long term. And then we do operations which unfortunately don't give good outcome in the long term. So my message with Dupuytren patients, if you have someone among your friends or family members, please try to inject early on. It's a painful injection because it's in the hand. It's painful. But I think it's worth trying. Again, we do it once a week, and once it starts to get better, every 2 weeks or every 4 weeks until it's gone. So please try to remember that. I think we had like an hour. I don't know if I still have a lot of slides, but I'm not sure how long
We can
I
go
can
ahead.
go on.
We
I can still talk a bit about the intramuscular injections, which is again typical for the glucopuncture. You don't find that in prolotherapy. You don't find that in the PIT. This is a technique that I have stolen from the American doctors and from some German doctors. And intramuscular is very interesting. I will go, for example, for the trapezius muscle, you inject like 1, 2, or 3 centimeters, depending. Stay away from the lung, of course. But if you use pincer palpation and you don't inject deeper than your own fingertips, you're safe. And as I said before, we use this 2 hands position. Then you have a good control of the depth of your injection. Here I show you calf muscle, intramuscular injections for a calf strain. Here, for example, patient with so-called hip pain, and because of the X-rays of the hip joint were normal, and I said, maybe you have muscular pain, because she said, yes, it feels like a fatigue. I also feel as if I have less power, and I injected in the gluteus medius muscle, like 2, 3, 4 centimeters deep. And this is a patient of 44 who has pain in the low back for 8 months, and he got again injections of 5 ml of sugar water 5% with a 4 centimeter needle. Of course, here for intramuscular, we typically use the perpendicular injection instead of the tangential injection technique for the fascia. And his pain disappeared after a few sessions. Just IM left and right. You stay away from the midline if you want to go 2, 3 centimeters deep. But then you can do it eyes closed. You don't need even ultrasound. Just stay away from that midline. And that's all you have to do. And sometimes we find pain points which are more painful. And then we also can find trigger points, like Trevor and Simon described, which refer the pain. And as I said before, you can have knee pain here, and you inject intramuscularly in the quadriceps muscle there. You can also do it for the gluteus medius and gluteus minimus muscle, but as I said before, then you need the 3-inch needle to inject here. So you look for deep trigger points here. Sometimes they're very difficult to identify, and then you use the photograph I showed you earlier with the 8 centimeter needle. This is a patient with pain in the frontal part of the shoulder, and I'm injecting the infraspinatus trigger point. This is an idea I've been stealing from Trevor and Simons again. They said if you inject the infraspinatus muscle, you may get relief from frontal shoulder pain. Usually I combine several spots. I also inject in the front, in the pain region, and combine it with, for example, trigger points injections in the infraspinatus muscle. The next layer are the tendon injections. This is also typical for glucopuncture. You don't find that in the PIT, for example. And we don't inject into the tendon. We inject very close to the tendon. And the major ones are, of course, Achilles tendon, but you can also use it on other tendons, right? And in contrast to steroid injections, there is absolutely no risk for tendon rupture. And you inject, we call it more peritendinous injections for Achilles, for example. And then the next layer, which is also important, is the ligament infiltrations. And ligaments are very popular among the American prolotherapists. And they sort of, by following the course with in Italy 20 years ago, I was like, it was like a revival of the importance of the ligaments. And as I said before, I mainly use it for traumatic events. When someone says, I have headache since I fell on my neck, or I have a whiplash injury, I always think ligaments. That's a very common one. And they are highly innervated and also receive minimal blood supply, which means that they are very difficult for them to heal by themselves, much more difficult than muscles, for example. And we inject, for example, collateral ligaments, the bands of the knee, ligaments of the ankle, and they can give both local pain and reverse pain. For example, the SE, the sacroiliac ligament, is a very popular one. So ligament weakness can also lead to chronic joint instability. In that case, then I will do prolotherapy. When I use the high concentration of dextrose, like 15 or 20, then you add some local anesthetic, and then your ligament will get stronger and tighter. And you don't get that with the glucopuncture. Then I will add or use my prolotherapy techniques. And that's what I'm saying here. Okay. This is, for example, a case of a lawyer who had pain in the back for 2 years. It was in the dorsal back region, which is quite unconventional, but it started after a fall during water skiing. And during the examination, I putting on the thumb on the supraspinal ligament in the mid-dorsal region. He said, oh, yes, that's it. Thank you, doctor. You are the first. I've seen more than 5 doctors. You're the first putting your thumb there. And I think, why is not everyone doing this? It takes you 10 seconds and it gives you so much information. And this information cannot be found on MRI. Therefore, you need your hands. You have them. Use them. And these are the points that I injected, but I found them with my thumb. And that was a lovely experience because I was so happy to have this patient being better. And I was just checking my messages so I can still go on a bit. Let me know if I had to stop, okay? Because once I get started, I'm so enthusiastic to share this all. You know, if you're doing this I'm doing this since 1986, almost 40 years. And I'm still surprised why is not everybody doing it? That's also why I'm sitting here, you know? Why is not everybody doing this? I've been teaching my injection teaching in the early days. We used to work a lot with Traumel. And I called it Biopuncture because the company from Germany, was sponsoring me. They were paying me for traveling the world to Russia, to America, to South America, to South Africa, to Canada, several countries in Europe. And we called it Biopuncture because it's a very general term, but it was mainly about the Traumel, that product. But these techniques are copy-pasted from that. But this is with the product glucose, which is available everywhere, and it's not expensive. You know, you can't patent it. That's why companies are not interested in it. But I think especially for low-income countries, it can be really a game changer. Let me see what else we have. Next slide. Well, this is an example of a patient with the same patient as I was talking about before, 5 times, as you can see, 5 spots with each 1 ml. And he saw a substantial improvement of the pain for almost a week. And then we just repeated it every 2 weeks because he was not living in the area. He had to do a long drive, but his pain disappeared completely and permanently. I saw him afterwards for other problems. So that was like, wow, this is really working. So here you see a section. You could also inject the interspinal ligament, but most of them I can handle with the supraspinous ligament, which goes all the way, even into the sacral area. You can have patients with sacral pain, and it's just the ligaments. And if you inject, don't do it this way, because if you would inject too deep, you might get too deep. It's better to take that's why I showed the photograph. It's better to point the needle downwards 45 degrees. If you accidentally inject too deep, you will touch the spinous process. You will never get into the spine itself. So this is more for safety that I recommend you to inject downwards with your needle instead of upwards. Another case of a patient having pain in the lumbosacral area, radiating into both legs, and we found several sore spots in the ligaments on the sacral midline. I was again the first doctor to do this examination, to look for these pain points. And they are very easy to find because they're very superficial. So I injected just in this area, in the sacral ligaments on the midline. And this is another case of a patient where I injected into the ligaments, a whiplash case. And the MRI was normal. And she went to see another guy, not me, a glucopuncturist, who was, again, the first to examine the nuchal ligament and found several ligament trigger points because the pain was not only local, but also referred. And also they found some points in the trapezius muscle, maybe secondary pain points. So the glucopuncturist injected the LTPs in the nuchal ligament, which is like 1 or 2 centimeters deep. And after 6 sessions, the pain was gone. Don't think I'm always successful. I also have my failures, and I try to learn from my failures. But if I don't share my let's say my nice cases, you will never get a taste of this. Please, you will one day you will get, and I will receive a mail from you and say, oh Jan, what you said is true. I didn't believe in the beginning, but now I've tested you, and I must confess, this is interesting. I'm not sure if we still have time to talk about the joint injections, but this is not here. The difference between prolotherapy and glucopuncture is vague, because here I think it's a matter of volume, of injecting a lot of sugar water, a lot of sugar itself. And the sugar will have several biochemical effects, whether it's dextrose or glucose, that's the same. I have used even 10% pure into the knee. It is quite painful, but to get more volume in it. Sometimes I add some procaine or lidocaine in it, but the more volume you inject, the more you get expansion of the joint membrane, but also the more molecules you get into the joint. And these are findings that, this is not my own research, but these are findings of the effects of dextrose in a joint. And let me see, well, something about the difference between glucopuncture and prolotherapy. I think originally prolotherapy is more sclerosing in products and using hypertonic dextrose. You can also do prolotherapy with hypotonic, because if you inject 2% or 3%, it is making the cells blow up and also collapse, and you also are creating tissue damage. That's why even low concentrations can have a prolotherapy effect. That's why when you one day want to combine the glucopuncture with another product, say a local anesthetic or Tромil or another one, please keep in mind the net concentration must be 5%. So if I would mix procaine 1% with dextrose, I would use an ampoule of 10%, and mix it 50-50, the procaine with the dextrose, because then the net concentration will be 5%. Normally, you should aim for 6%, because real isoosmolar is 6%. But we say that between 5 and 7% is a isoosmolar solution. I will skip all those. This is the website I was talking about, sweetsolutionformedics.com, where you can find the free online course on glucopuncture with some beautiful videos, including one video by Professor Lam from Hong Kong. By the way, have you seen on PubMed, I have also a publication with him and Dr. Suryadi from Indonesia about the application of glucopuncture. And these are the websites where you can find them. I think we have about finished the presentation that I wanted to share with you. But if you are still available and still have time, we can still have some questions. I will push on my loudspeaker. It's better again. Less echo now. A little bit just. Are there any questions or remarks? All was clear. I forgot to tell you that my book is published in India. This one. There, I still use the subcutaneous injection, and I don't mention the fascia yet, because that is quite a recent, let's say, finding. When Professor Lam was discussing the importance of fascia, I was the next speaker. This was a webinar a few years ago in Indonesia, and he was talking about fascia, and I said, oh my God, now I can explain why my subcutaneous injections give all these effects. So I still am very grateful to him for that lecture. If you want, side effects are very seldom. You can injure with your needle. If you want to be 100% sure, you will have to use ultrasound. Okay. Otherwise, any questions? Everything is clear?
Hello.
Yes.
Well, Dr. Jan. So,
Yes.
do you have any more slides to complete? Because we have time.
Can I go on? Because
Yes, please go ahead. Please go ahead.
Oh, okay. Let's say that I'm now talking. Well, I could take some new slides if you want, because I have many. But maybe it's sometimes interesting to just share a patient that I saw today. So the patient comes to see me and has seen several doctors for chronic low back pain going in both legs. They did the MRI, they do all the examinations, they don't find anything, and he is diagnosed as having neuropathic pain in both legs. And he is taking Neurontin and other conventional medication for neuropathic pain. I said to him, let's give this a try. I'm going to give you these sugar water 5% injections in your low back area. And I didn't find, unfortunately, that was a bit of disappointment for me. I didn't find any pain points or trigger points in his ligaments and in his fascia. But this is not a subject for today, but I will mention today, we also have the idea of the origin region. The origin region is, let's say, the sleeping culprit, where the patient doesn't have pain, you don't find pain points, and yet it is the cause of your pain. And over the years, I stole the idea a little bit from the osteopaths as well. I was myself a back patient, and I also went to see in those days an osteopath. And that was not for sciatica, that was for low back pain. And he said, oh, but I usually work on the dorsal area to treat low back pain. And I said, why is that? Oh, we osteopaths, we do that for decades. We think it's normal. And I didn't have an explanation. Now I do with the fascia. And now I'm mixing two patients. I will go back to the first one. The one with the low back pain and in the two legs, I started to inject the dorsal area, the lumbar area on the fascia midline. And believe me or not, this is for testing, this is not for believing. After 3-4 sessions, he said, for the first time, I could diminish my pain treatment, which I was taking for months. I'm not sure how long exactly, but for months. And we haven't finished treatment yet. We still have a few sessions to go. But he says, this is the first time in all those time that I'm suffering from this neuropathic pain And I'm just giving him sugar water on the midline, on his dorsal area and lumbosacral area. It takes me 30 seconds. 30 seconds. You can see a patient every 10 minutes without it's easy, it's quick, but not just to be quick, it's safe also. And I'm still amazed by the results that we see these days. Then the other one, about talking about the dorsal area. I have had several patients now with chronic lumbar pain, low back pain. They show you the area, low back pain, left, mid, right. X-rays, normal. MRI, normal. Still have this pain. It's worse when bending over. Sometimes they wake up in the night and so forth. And these days, I always combine with dorsal midline on the fascia. This is not in the books yet, but I will publish about this. It's amazing how we see that the fascia, remember the lady with the fishnet on her back? Think about that. It's all connected. I didn't know that before, but now these days, there's a lot of research going on about fascia and the superficial fascia. And we notice that is like a forgotten organ. It is, I don't know, is it 8 times more innervated than muscles? Can you imagine? It's very thin, but it also has a mechanical importance. They call it fascial integrity. It connects everything. It also connects deeper. It also connects with internal organs. That's why we used to do that with the biopuncture already, that we injected patients with chronic cough here in the sternum, in the stomach area for gastritis and so forth. We do the same with the glucopuncture. And I have one article, or no, I think I have two now. Yes, I have one on IBS, irritable bowel syndrome, and I have one on gastritis. I should have another one, but I didn't have time yet about the chronic bronchitis. You simply inject subcutaneously in the fascia in the region of the pain or the complaints. And sometimes I also combine it with the backside. You do the midline on the same level. And after a few sessions, suddenly patients start to feel better. And I hope someone listening here or someone who's reading my articles will do some research, because all I have is the fascia, the interstitium, the extracellular matrix where we inject, but all the mechanisms, there's still a lot of mystery. And but it's a very promising part of the glucopuncture. So glucopuncture is not just about musculoskeletal pain, it's also about what we call organ bioregulation. This is not about treating lung cancer or gastric cancer. This is about functional complaints, which can be very annoying for the patient. It can be there for weeks, months, or even years. It's really worth trying. And I am very keen to share this also with Indian doctors, as I do for the first time now. The new book that will come will probably also have in Chinese. We hope to reach more countries, maybe also in Africa, where we can share our findings. But it's, especially in Europe, it's difficult because here medicine is what we call so-called evidence-based medicine, which sounds good. We don't have so much evidence-based for glucopuncture yet. We only have for carpal tunnel syndrome, we have now 5 RCTs on PubMed. For epidural glucose 5%, I think 1 or 2. But the problem is nobody's interested in investing a lot of money, because a good study costs a lot of money, especially in Western countries like here in Europe and the United States. I don't know about India and China, but here it's a lot of money in a product which doesn't have any promises for gaining back your investment. You're investing in a product which cannot be patented. Nobody's going to do that. You need a university or an organization who wants to help patients in a safe manner and doesn't think about money. These guys should do the research for us. And not just for the carpal tunnel syndrome, but hopefully also for the injections we give in fascia, the injections we give into the muscles that we have discussed today, the injections that we give into the ligaments. And it's so much fun to have a practice like that. And recently I had a pain specialist from Belgium who is an anesthesiologist, but also pain treatment in the hospital. And she came to visit me in the office twice. And she said, I would love to do what you're doing. but it's not going to be easy to introduce this in a hospital. I realize that's not going to be easy. But if we get more research on this subject, if we get more clinical studies, we really might change the future. And I hope India will be one of the pioneers of, the first time I came to India was in 1989, November 1989. And we did the whole trip. We went to Bombay, we went to Udaipur and Jaipur and Khajuraho and the Taj Mahal and well, so many things. It was amazing. And I went again to India for, let's say, 4, 5, 6 years ago to see Ranthambore, to see the tigers. We saw Ajanta and Ellora, most amazing caves that you can see in your life. So, and also I have studied a bit Indian philosophy, like Advaita Vedanta and so forth. So I like India a bit more than the other countries, but I really hope that some of the doctors who are listening or afterwards are going to be able to listen to this recording, maybe could be inspired to do the same as I'm doing, share their experiences, both the good ones and the bad ones. I learned most from my bad experiences over the last 39 years and spread the message. That's also the goal of my talk today. So I want to talk, I want to thank the organizer for taking me here with you for this lecture. And I hope that Dr. Javed is pleased with what they've done so far. And let's go for the question. I just saw the message, 1622.
Thank you very much, Dr. Hello.
Yes, please. For the question.
Thank you very much, Dr. Jan, for the insightful presentation. And I'm very sure that the different techniques, what you have shown, are an eye-opener for most of us who are practicing chronic pain. And I'm also again very sure that from this part of the world, a lot of people would start employing these techniques as well.
Yes.
So now we'll just go into the question and answers. So
yes, please.
a few questions in the chat box, which I would like you to see. I think 1 second.
I can't hear you.
Can you see the chat box?
I'm there twice.
Yeah. So I think one question, hello, was on
Yes.
people wanted to know more about intrafacial injections. What size of needle are you using and everything? So could you help us with that?
Yes. Let's say that if you are a beginner, I'm going to switch off my loudspeaker, too much echo. If you're a beginner, you can start with a subcutaneous needle, like a 27 gauge needle, 1 centimeter, maybe 2, but 1 is enough. But I prefer 2 because we inject tangentially, like 10, 20, 30 degrees to reach as much as possible, as much as tissue of the superficial fascia as possible. In the beginning, we only injected 0.5 ml on each spot. Then I switched to 1 ml and I saw the results were better. These days, but it's not on paper yet, I didn't publish this yet, we inject even sometimes 2 cc, 2 ml on each spot. Don't be afraid to inject too much. Even diabetics, even patients who are on a strict diet, the sugar water is metabolized locally. I say to my patients, we are recharging your batteries because the glucose is turned into the ATP in the mitochondria and it's recharging the batteries of the cell. So regarding the technique for fascia, it's just subcutaneous, and you will watch my videos on the free online course that I mentioned to on Sweet Solutions for Medics, and then we'll see a few of these injection techniques applied with a 5 cc syringe and a short 27 gauge needle.
Yeah, thank you very much. Another question was
I have to push
how
on
do
the
you
speaker.
manage the post-injection pain, sir? Like after the procedure, the various pain complaints which patients have. So how do you manage that?
Well, let's say we use a lot in Europe the Tromiel cream, which is based on arnica. You can use arnica creams. And if the patient has a lot of pain, you can apply ice. But if possible, don't do anything and move about. And it will subside normally within a few hours, maybe a day. But usually it doesn't require any treatment.
Okay. And one more question which I remember was people were inquiring about the subcutaneous injections. So could you throw a little more light on the subcutaneous injections, what you had just explained?
The fascia injections are
Yeah.
subcutaneous, the one that I discussed here.
Yes.
Okay.
Yes.
So I'm not getting the question right away. You can't get away of the echo?
The echo.
Yeah, because I'm here twice, and that's probably the reason. No.
Can you try unmuting yourself?
Fix it, but I can't. Can
Yeah,
you
now it's
hear
better.
me?
Yes, yes, better now.
Okay. I can't get away with the echo.
Huh.
Anyway,
It's okay. It's okay. It's okay.
another question?
Yeah. So one more question is like usually you mentioned about the sessions for the glucopuncture, what you do. So ideally, on an average, how many sessions do you do, and how do you space out these sessions? Like, what is the time gap between each session?
Okay. So as I explained in one of the slides, for fresh injuries, you can go quickly. For example, you have a soccer player or basketball player with a calf injury. They come on the Monday and they come on the Wednesday and the Friday, or they come on Monday and Thursday, and 2 sessions should be enough, sometimes 3. So you do a lot very quickly. If you have a patient who has pain for 3 years and it's chronic, you might say to the patient, come every 2 weeks. But if you're very, let's say, impatient, I see them once a week in the beginning. And once it starts to get better, every 2 weeks, then every 3 weeks, then every 4 weeks. I say that from the beginning, we will need between 5 and 10 sessions. And I say also to them, which is more important, it can get worse a bit in the beginning, or the pain can change, relocate a little bit. These are all positive signs, no need to worry. But apart from some arnica cream or some ice application and some rest, there's not much you can do. But usually, because of this product is quite friendly, it's not so much to worry about.
Okay. So again, as much as I can understand, you are as of now doing only glucopuncture, 5% dextrose for your procedures. Prolotherapy is
Oh,
you
yeah,
want.
yeah. I still apply my neural therapy that I learned in the 1980s, which is procaine, and
Yeah.
inject it also into scars, into interference fields, and so forth. That's my first step in this type of medicine. I also apply sometimes, but it's very rare now, mesotherapy, which is a French technique, but it's not so common anymore that I use it. Then I also do the prolotherapy, as I said, mainly for weak ankles, weak ligaments, like for the ankle and so forth. Then I also do some PIT, but I prefer my own technique. I learned the PIT a few years ago in Greece from Dr. Cavallino, which is a very, very good technique. But I have my own technique for all these decades. And I sometimes use some of their ideas, but I'm not a real PIT man. I'm more like the glucopuncture. It's like my own techniques. And instead of the using the Traumil, we are now using the glucose of 5%. But in my office, I choose and I see what's best for each patient.
Perfect. Perfect. Horses for courses. Right. So next question, what people are asking is they're asking more about the facial injections. Is there a video or a few pictures if you can just show them again about the facial injections?
I
Facial
think
injection.
I would recommend them to go to the Sweet Solutions for Medics website, and there you scroll down halfway and you have direct access. You don't have to give your mail, you don't have to give your phone number, you don't have to pay, direct access to 200 slides, including 20 videos. And there are a few of them here. If I wouldn't have these technical problems here, I can try, but I'm not sure. Something went wrong a few times today. Otherwise, I can look for. I have many videos, but they are quite easy to accessible.
What is the website again, sir? Could you just show the name of the website again for the
You
participants?
see, it is Sweet Solution. Here it is.
Sweet
Sweet
Solution.
Solution for Medics.
Okay, I hope all of you are taking screenshots of this. I myself am. So Sweet Solution for Medics is
Yes.
one of the website. You can go in there. I think as sir told, it's totally free. So you can go in and you
Totally
can.
free website. Yes. And if you want to get started, this is perfect.
Perfect. Perfect.
Okay.
So, Dr. Jan, just out of curiosity, I see that you've been doing the injections using your blind techniques. So, anytime, do you also use an ultrasound as well for any of your
I
techniques?
have about 10 years ago, I wanted to try ultrasound.
Yeah,
And for some reason, don't ask me why, it didn't work. I'm very more like intuition,
yeah,
listening to the patient, touching the patient, looking for the pain points. I was doing that for all these years. And then
yeah.
suddenly that machine, I was watching a screen. I thank God I didn't buy the machine. I could try it for 2 weeks and I gave
Okay.
it back. But I still believe the ultrasound is a fantastic tool for specific difficult injection techniques and for safety. You can't go blind deep into the neck
Yeah,
as they did in Germany in the 1980s. No, these
yeah,
days you can't do that anymore. You need ultrasound. And especially if you want to do the carpal tunnel ultrasound
yeah.
guided perineural, I can't do it
Mhm.
blind. I only inject fascia and the fascia here. And
Yeah,
sometimes I have good results, but if that doesn't work, I need to find a doctor who has ultrasound and uses the glucose or the dextrose instead of the steroids. But ultrasound is a beautiful tool of the 21st
true.
century, for sure. Yes.
Totally agreed. And actually, after listening to your presentation today, I myself have been practicing prolotherapy for the past almost 6 years now, and
Oh, that's nice.
it was a very good. And I have been seeing very good results with it. And today, after looking at your presentation, I have to rephrase what I just said. I've been practicing glucopuncture only, not prolotherapy. I use
Well,
5%.
you can do both. They're like a brother and sister. They're not enemies.
Exactly.
Because I
And
had people with
yeah,
doctors that said, why do you give it a new name? But this is not in competition. You can do both and you can continue to do your prolotherapy. But in some cases, you will recognize, for example, the referred pain of the knee. You will check and say, oh, Jan said about the trigger point. Let's see. And then you will think about me, I hope.
yeah. Yes, yes, yes.
You will
Actually, as a
see.
matter of fact, I have been using 5% only for most of the procedures, for the trigger points as well. But only thing is that I use ultrasound for all of the
Okay.
procedures.
Please
And
continue to do it.
I do a
But
lot of
don't forget the
cervical
trigger
prolotherapy.
points. Don't forget the referred pain. You
Yeah.
don't see it on ultrasound. So
Yes,
maybe
yes, that's very true.
you can still
So,
combine.
one more, I think we have a couple more questions over here. So one particular thing is, yes, so one question which people have asked, since it's a sweet solution, a sugar solution, so how about the usage in diabetic patients? Can we do it in well glycemic control ones, or is there any contraindication for using in diabetic patients?
You mean diabetic?
Diabetic patients, can we use your
No
glucopuncture?
problem.
No problem.
5% means 95% is water.
Yes,
95% is water. If
correct.
you inject 10 cc, it's maybe like I don't know, two strawberries, and they're eaten locally. They don't go into the blood. They go into the cell, ATP, charging the batteries. No problem. You can have maybe 1 in 1,000 of allergic reaction with some itching. I had 2 or 3 patients over decades. So it's very seldom.
Yes. So another question has come wherein can you explain about the mechanism of action again?
Oof. You have to read the books.
Yes.
Yeah, I have like 20 articles, including 3 or 4 on PubMed, and please read that with all the references. But there's still work to do. But what I say to my patients, we recharge the batteries of your cells. But I say to my colleagues, substance P and TRPV1, vanilloid. Forget, and the rest you can read. I'm not so good in the theory. I'll leave it to the others.
Dr. Jan, another question that what is your take on combining prolotherapy with PRP?
Well, I don't practice the PRP myself. I think it's a very good treatment. I think it's the best replacement for steroid injections. So if I have colleagues here in Europe who don't want to do the glucopuncture, I say at least start to apply the PRP. And after PRP, you can do some prolotherapy. And because for them, the glucopuncture is too simplistic, you see. So PRP is a wonderful technique. It's also financially sometimes interesting in some countries for the doctor, but it is a very safe and effective treatment, yes. But I don't apply it myself.
Yeah. Another question we have over here, Dr. Jan, is they're asking how do we make buffered dextrose solution? Buffered dextrose solution.
I don't use it. It's only Dr. Liftoff who is doing it. You have to add some bicarbonate. Bicarbonate. You have to use a little bit of bicarbonate to get the acidity to pH 7.4, but I don't use it. You have to ask him.
Yeah.
Or maybe Dr. Cavallino. That's his friend.
Okay, great. Right. So I think one last question is, can we inject dextrose into the joint intra-articularly?
Of course, yes. We didn't talk about it today, but most of the old studies are all about joint injections, and they call them prolotherapy without having any proliferation. That was, again, a misnomer. But yes, of course, you can inject into a joint. I think I discussed one in the beginning of a joint. No, not today. No. But yes, of course, you can inject into a joint. And you can add a local anesthetic, but it also works without a local anesthetic. Yes.
Yeah. So in case a local
I showed you. Let me see. Here it is. Biochemical effect, that's joint injection. And if you want to know the mode of action, here they are. But this is for joint injection.
Yes. Another question we have, Dr. Jan, is if lignocaine is added to the concentration, does it compromise the solution? If yes, what?
Say again.
Yeah.
I didn't understand.
If lignocaine is added along with the 5% in the injections, will it compromise the effect?
No, it will not compromise the effect, but you have to be careful. Stay with a net concentration of between 5 and 7. So if you use 10% glucose and you take 6 cc and you add 4 cc of lidocaine, your net concentration will be 6, which is perfect. But if you take 5% and you had a lot of lidocaine, it goes down. And then you're starting to do prolotherapy because too low or too high gives cell destruction. I told you about it in the beginning when I explained the difference between prolotherapy and glucopuncture. That was also one of the reasons to introduce a new term. The prolotherapists in America, some of them like me, some of them don't like me that much for that. But I had to introduce a new term. It is not prolotherapy. Look for the definition, the original definition of prolotherapy, and they will say it's cell destruction and then proliferation after a few weeks. And I'm so sorry, that's not what you do with the 5%. But adding the lidocaine or procaine can be a good idea. Also, the procaine or the lidocaine itself has an effect. Look at the TLA, therapeutic local anesthesia from Austria. Look at the neurotherapy from Germany. They only inject the local anesthetic. So in the beginning, that's what I was doing, combining both. So yes, you can combine.
Great. So I think we have come to the end.
One more last question, maybe.
Now I'd request if any of the participants have any question, you can unmute yourself and you can directly ask Dr. Jan.
I can't hear.
Hello, am I audible? Hello? Hello, am I audible?
Yes, sir, you are audible, sir.
Okay. I think Dr.
Hello?
Yeah, Dr. Jan, am I audible? think some technical issue.
Yes.
Yes, sir. You're audible, sir.
Okay, thank you, thank you. Dr. Jan, you're with us?
Yes.
Yeah. So I think the last question is for actually carpal tunnel, what concentration do you use?
5, 6, or 7.
Perfect.
Yes.
Yeah. So I think we have come to the end of the questions,
Yes.
and I would like to take this opportunity to extend my heartfelt thanks to Dr. Jan Kershot for
My pleasure.
agreeing to be a part of our webinar at a short notice and teaching us so much, educating us, sensitizing all our participants about the importance of glucopuncture and how we can apply it in our practice as well. So,
Yes.
any last words, Dr. Jan, from your side?
Thank you so much. Namaste. Namaste.
Thank you. And it will always be a pleasure. Looking forward to have you again with us in our.
We will stay in touch.
We'll stay in touch.
Wonderful. I look forward to it.
Look forward.
care.
Sure. Thank
Bye-bye.
you. Thank you, sir. And I'd like to thank all the participants as well for being a part of this wonderful webinar. Thank you all. And we look forward to meeting you all again in our next webinar series. Thank you.
Oh,
Good evening.
take care.
Good night.
Bye-bye.
Yeah.